Hi, everybody. We'll just give it a few seconds, let everybody join. This is the last Woo You event of 2023. So Dr. Rodman, you get to end on a great note. It's been a great year, and I'm always happy to be here with you. So what a great way to end
Likewise.
this amazing year of Woo You. So welcome, everybody. I know that everyone's got a lot of stuff going on with the holidays, so we'll get started. Good evening and welcome to tonight's Woo University Diseases of the Vitreomacular Interface and Macula with Dr. Julie Rodman. I'm your host, Dr. Jennifer Stewart. It is my great pleasure to, once again, I think this is our second or third time, at least second, probably third time together. I get to introduce Dr. Julie Rodman. She's the chief of Broward Eye Care Institute in Fort Lauderdale, Florida, and a professor of optometry at Nova Southeastern University. She is also the instructor of record for posterior segment disease at the college. Her research interests include OCT, OCTA, and vitreoretinal disease. Dr. Rodman has authored over 30 publications with an emphasis on retinal disease. She recently published Optical Coherence Tomography Atlas, a case study approach, the first reference book on this topic written by an optometrist. She's a member of the AOA, AAO, FOA, and ORS, and has been the recipient of numerous teaching awards. She was recognized as a Primary Eye Care Optometry News Top 300 Optometrists and Newsweek's Best Optometrist of 2022. She's also a Woo You favorite, and we get tons of requests for more Dr. Rodman. So we're super excited to have you here, and I'm going to turn it over to you.
Thank you, Dr. Stewart. You're a sweetheart. I appreciate it. So this topic is actually one of my favorite topics because when I went to get my master's, I did my thesis on vitreomacular disease. So it's something that I'm very passionate about, and I'm excited to be here tonight to talk to all of you about. So I want to start off really with understanding exactly what the vitreous is and what its relationship to the retina is. So we know that the vitreous takes approximately 4 milliliters of the human eye, and really the contents are about 80% of the eye. So we don't think about the vitreous as being such a heavy hitter, but it really, really is. It's composed of about 98 to 99% water and about 1 to 2% solid. And the solids are made up of protein, hyaluronic acid, and collagen fibrils. When you look at this photo on the top right of the slide, you can see the matrix of the vitreous there. You have this hyaluronin, and the collagen fibrils actually look kind of like spaghetti, and they make up the matrix of the vitreous. So this is kind of a schematic here of the vitreous and really the posterior vitreous cortex, which is essentially the same as the posterior hyaloid, or the aspect of the vitreous that sits closest to the inner limiting membrane of the retina. And you can see that the posterior vitreous cortex, again, is made up of many adhesion molecules. And these adhesion molecules are things like fibronectin, proteoglycans, integrins. And these adhesion molecules play a really big role in keeping the vitreous opposed or in contact with the inner limiting membrane of the retina. We also know that the vitreous is attached in many places to both the retina and the lens. So when we talk about retinal points of attachment, we have the vitreous base at the aura, we have the macula, the optic nerve head, and the retinal blood vessels. And we know that it is attached to the posterior aspect of the lens at something called Weiger's or Weger's ligament. We also know that the vitreous is attached with different strengths to different parts of the retina and adjacent structures. So when we look at kind of the arrow here, the top of the arrow, meaning vitreous base at aura, that is an area that's very, very strongly attached. Then it followed by the posterior lens, optic nerve head, macula, and retinal blood vessels. And why this is important is that when you think about the vitreous detaching from the retina or other locations, we really want to think about the strength of these attachments because, bleeding or other sequelae are more common to happen in locations where the strength of the attachment is stronger than in other locations. So I want to kind of start off this whole presentation after we just talked about the anatomy of the vitreous with this question. Is the vitreous our friend or is it a foe? And really, I would say that it can act in both contexts, really depending on the person that you're talking about. So you all know, whoever knows me knows that I love OCT. And I think it's very important that we do a really quick review, just kind of the vitreoretinal or vitreomacular interface before we delve into this topic. So on top of this OCT scan, this OCT-B scan, is this black area. And this black area is essentially the vitreous. And I would tell you, and everyone that's watching this probably knows, that it's very rare to look at an OCT scan and see a vitreous that looks that black. Essentially, when you're born, right, the vitreous is attached everywhere that it's supposed to be, so it's going to look like that. In a patient that's had a complete vitrectomy, right, there's nothing that's going to be floating around there. But it's very uncommon, maybe in a PVD, right, where the vitreous has migrated so far in the scan. But normally you're going to see something floating around in this vitreous space. And we're going to talk about that throughout the course of this presentation. The first layer here, this highly reflective layer, is the inner limiting membrane. And I mentioned before that the posterior hyaloid, or the posterior cortex of the vitreous, kind of resides or attaches with those adhesion, molecules, or those adhesive molecules, to the inner limiting membrane of the retina. So diseases of the vitreoretinal or vitreomacular interface are going to originate essentially in this vitreomacular area. That doesn't mean that we don't have to look at everything else within the neurosensory retina and south, because anything can be affected. But this is where the problems are going to originate. I also want to emphasize that the most important part of the OCT in determining a patient's visual prognosis kind of moving forward is really to look at this hot spot in the center here, which we look at the photoreceptor integrity line right here. And the photoreceptor integrity line are rods and cones. In order for a patient to have really good vision, like 20/20 or better, that photoreceptor integrity line, densely packed cones, the interdigitation zone of the RP, this area in here needs to be intact. If there is a break somewhere in what I'll call the pill in this area, it's really by definition not possible for a patient to have 20/20 vision, unless they're eccentrically fixating. So when we talk about vitreomacular interface disorders, if they begin to involve that photoreceptor integrity line in the surrounding areas, we need to really start thinking about how we're going to change the management of these patients. So as we age, there are two processes that are naturally going to occur. The first one is called synthesis, or the liquefaction of the vitreous gel. When you look into the patient's eye, you're using your 90 diopter lens, you focus behind the lens of the eye, you look at the vitreous, and you see kind of what I like to call egg yolky stuff floating around. That's actually the liquefaction of the vitreous body. My students like to always write syneresis, and it's actually very difficult to see syneresis, which is the contraction of the vitreous body. What you're visualizing is actually the synthesis, or the liquefaction of the vitreous body. The second thing that does happen, though, is the contraction, or that anterior displacement of the vitreous. And these two processes happen in tandem. So the idea here is that if they accompany each other, patients are going to have normal age-related processes and minimal complication. On OCT, it's very, very helpful to kind of assess that synthesis or the syneresis. So this is a picture of that liquefaction process. On the top right, you can see these lacunae, or fluid-filled pockets, that are happening from that liquefaction of the vitreous gel. On the OCT scan, you can see these big black cavities within the vitreous, which again are the liquefaction of that vitreous. You'll also appreciate that anterior displacement. You can see here that the entire vitreous is moving anterior in a scan. But when you see these lacunae, these pockets like this, that is the synthesis of the vitreous. This OCT scan is a nice example of the syneresis, or the anterior contraction. So again, if you look at this, the posterior hyaloid lifting up here, this entire thing here is the vitreous moving anterior in the scan. Another example here of a really nice example of that anterior displacement. So looking behind the slit lamp, I would say you certainly would be able to see the liquefaction. I think it's a little bit more challenging without an OCT to appreciate the syneresis, or the contraction of the vitreous. Things to keep in mind, our vitreous actually begins to liquefy at 4 years old. And as we get older, as we age, that liquefaction is going to increase. So in your late teens, 20% of the vitreous is going to be liquefied. And when you're 70 and older, half of the vitreous is going to be liquefied. And that's why we know that These diseases are extremely prevalent as we get older, right? Because this is an active dynamic process that tends to increase in frequency as we get older. So this rubric is how we're going to move through the presentation. Essentially, we're going to talk about a normal PVD, or a normal posterior vitreous detachment, that is going to take place in 4 stages. And then we'll go through the anomalous PVDs and what happens when the PVD doesn't happen naturally, or normally, I should say. So when the synchesis and the syneresis happen in harmony, okay, so when they take place in the appropriate fashion and they accompany each other, we get a PVD. Okay, so we get liquefaction, we get the anterior contraction, and that posterior hyaloid is going to slowly release itself from the retina and the optic nerve. When one of them precedes the other, or when something happens with more force than the other, that is when we begin to get these anomalous PVDs. So when you look at stages of PVD, what you want to look for is essentially the posterior hyaloid, right? The posterior vitreous cortex. You want to look at its relationship to the underlying retina. So what you can see here is that arrow 1 and arrow 2 are showing you the posterior hyaloid. And what I want you to appreciate is that even though you can visualize that the beginning of the hyaloid lifting up, the vitreous, the hyaloid, I would say, is still attached at the macula. And even though you can't see it, it's attached at the nerve as well. So we can begin to see this separation, but it's a very subtle separation. A lot of literature, research papers refer to stage 1 and stage 2 PVDs as vitreomacular adhesion, because essentially the vitreous is adhering. Remember, we talked about that, those adhesive properties of the vitreous that's keeping it in apposition to the ILM. So you can say that stage 1, stage 2 PVD are also called vitreomacular adhesion. Stage 2 looks similar to stage 1. The only thing that you're going to appreciate now is that these pockets of separation have gotten bigger. There's still attachment at the fovea, there's still attachment at the nerve, but you're seeing more of that displacement between the posterior hyaloid and the inner limiting membrane. A couple years back, many years back actually now, there was a group called the International Vitreomacular Traction Study Group. And they looked specifically at classifying VMA, VMT, and macular holes. So very, very briefly, I'm just going to kind of run through these. If you want to classify VMA, or essentially an incomplete PVD, either stage 1 or stage 2, the IVTS group said that you can call them either focal versus broad, or isolated versus concurrent. So let's look at these. Essentially, focal VMA means that if you were to measure the points of attachment of the vitreous to the ILM, it's going to measure less than 1,500 microns. That would be focal, again, looking at point A to point B. If the points of adhesion are greater than 1,500 microns, it's considered broad. Is this important in the scheme of things? Probably not. I'm just mentioning it to kind of make this lecture complete with classification for classification purposes. For isolated versus concurrent, isolated essentially means that the VMA, or the incomplete PVD, is happening on its own with no company. Concurrent means there's something else going on. So for example, the top image would be a focal VMA, right? We can see that the points of attachment are less than 1,500 microns, and there's no other disease pathology going on the slide. So it's an isolated focal VMA. The picture on the bottom is also another focal VMA, but the difference is you have a choroidal neovascular membrane here with a serous PED. So this one would be called a concurrent VMA, because the VMA is happening in the company of other disease processes. So what do we do with these patients? We all probably don't even know half the time patients have stage 1, stage 2 PVD unless they're symptomatic. See them in a year, If they have symptoms, or if you happen to do an OCT and find other disease states, meaning it's concurrent, then certainly we want to reconsider our time span. But in the case of a regular patient that's asymptomatic and you're finding it on routine exam, a year is definitely appropriate. Moving on to stage 3, what you're going to notice now is that the vitreous is now detached from the fovea, still attached at the nerve. Okay, so when you no longer have attachment at the fovea, but you still have attachment at the nerve, then we're in a stage 3. And we all know that the last stage, which is accompanied by what we call a Weiss ring, is when that vitreous fully detaches from both the fovea and the optic nerve head. So once you have complete vitreopapillary release you're now in stage 4. And that's how we categorize a complete PVD. And I would argue that it's super important to classify them if you can, because if a patient is symptomatic, what you're going to do for them is going to differ a lot depending on whether there's still attachment of the vitreous versus whether there's been a complete PVD. Notice that in this OCT, you can still see the vitreous floating up. It's still contracting anterior. Notice in the slide on the picture on the bottom, the vitreous looks black because the vitreous looks black because you can't see the PVD that is so far up in the scan. So be careful. It can look different ways. As far as management goes, any patient that's symptomatic, you certainly have every right to refer to a retina specialist. That's always an excellent answer. What I would tell you is that if you choose to follow them yourself, I would follow them pretty closely, meaning at least in the first, week 1, and then bring them back again in week 2, because things can happen. We know with the retina, it's dynamic. And even though they may look fine that day, they might not be fine a couple of hours later. Remember that scleral depression plays a huge role. So what I would tell you and what I tell my students is that if you don't feel confident scleral depressing and a patient is symptomatic, you probably should refer it out to get the opinion of a retina specialist. Any patient that's symptomatic, certainly highly consider referring out. Let's look at an example here. This is a 73-year-old female who says, I feel a film of cobwebs over my right eye that started a year ago, but she says it's progressively getting worse. And I love when they tell you, I had cataract surgery a few years ago. Is it related? Right. So certainly whenever patients have surgery, they think that it was, and it could have been, right, the fire behind what happened here, but certainly not 100% the reason that she's symptomatic. She's 20/40 in this eye. And here's her OCT. So, hopefully just by listening to what I just mentioned, looking first of all at that posterior hyaloid, looking for points of attachment, and the white arrow is pointing to that posterior hyaloid. So, here's the question. What are we seeing? Is this a complete PVD? And remember, the definition of a complete PVD is that the vitreous has fully detached from the nerve as well. And you can see in this image here that the vitreous is still attached. So certainly not a complete PVD. Is there partial detachment of the posterior hyaloid from the central fovea with persistent attachment at the nerve? That certainly seems appropriate. And is there vitreomacular traction? We haven't talked about that yet, but there's no evidence of VMT in this picture. So number 2 would be correct here. As far as a management perspective, remember, she's symptomatic. Okay. She's symptomatic and it's fairly acute. She says, well, it's been going on, if you want to call it acute like that day, no, but it's been going on. It's not the longest thing in the world. But the fact that she's symptomatic, would you refer? Would you not refer? It's not a bad idea. My thought is that she probably is symptomatic because she's still in the process of detaching here. And I personally would probably follow her. But remember, it's never wrong to refer if the patient is symptomatic. So here's my, my kind of clinical pearl from before. If you're going to bring them back, and if you feel confident in your retinal exam, make sure you're bringing them back within that first week. And then certainly a week 2 to make sure that you're not, that no changes have happened. Okay, so that was kind of going through normal PVD, the 4 stages, and what should happen in the perfect world. But as we know, most diseases of the vitreomacular interface actually are from anomalous PVD. And there are 4 main categories that happen with an anomalous PVD. So the first one is an epiretinal membrane. So think about what we talked about before. We have this process of liquefaction. We have this process of contraction. What happens if the posterior hyaloid or the vitreous is trying to detach from the retina and it doesn't detach, let's say, in a timely fashion, or it's lingering a little longer than it should? Residual vitreous actually is going to adhere to the inner limiting membrane of the retina, and it's going to proliferate. Okay, it's an abnormal response, and you get proliferation. That proliferation is actually affecting or being caused by or at the glial cells. It's a proliferation of the glial cells that live at the inner limiting membrane of the retina. That glial cell proliferation is called an epiretinal membrane. Okay, so when I ask the question in my retina course, what is the most common cause of an epiretinal membrane? It's an anomalous PVD. Okay, it's when that PVD is not happening in the correct time or fashion that we want it to. There's actually multiple or two types of epiretinal membranes. The kind that we most frequently see is a grade 1. And what you'll notice here is this overall cellophane-like appearance to the retina. But notice that the blood vessels are not changing trajectory, meaning that they're not being affected by that glistening or by that epiretinal membrane there. In a grade 2, the epiretinal membrane is so thick and so fibrotic that it takes the blood vessels with it. Okay, so it's almost like putting this extra tractional force on the tissue around it. Some stuff to keep in mind is that the risk of developing ERM, we said this before, is going to increase with age, strictly because all these vitreous changes become more prevalent as we get older. And people with or patients with predisposing conditions may develop ERM at an earlier age. Just kind of looking at statistics here, patients greater than 50, so let's say from 0 to 50 years old, have a 2% chance. Once you're older than 75, you have about a 20% chance. So a 10-fold risk of getting an ERM. In about 10 to 20% of cases, both eyes will have ERM, but they can be varying degrees of severity. And we all know what an OCT of an epiretinal membrane looks like. You can see that really nicely in this image. This is that anterior contraction of the vitreous body that probably caused this epiretinal membrane to form over time. And you can see the sawtoothing of the inner limiting membrane, which really is a result of these adhesive properties of the posterior hyaloid that almost cause this kind of pinching of the retina, because those were the points of attachment. And this is more of a flatter appearance, but overall thickening of the retina. And down here, this jagged appearance, just differing appearances of epiretinal membrane on OCT. Remember to keep in mind that we always want to look at the photoreceptor integrity line, the integrity of it, because that's going to really dictate the majority of what the patient's vision is going to be. So treatment and management of ERM. Think about referral in these situations. If the vision is less than 20/60, so most retina specialists are not going to touch a patient unless they have that visual acuity or worse. The caveat to that is if they're symptomatic. So if they're experiencing diplopia, metamorphopsia, any type of symptom related to the ERM, that would kind of go against or argue in favor of having a surgery versus just vision. And what usually is done is they will go in and they will peel the membrane and do a vitrectomy if indicated. 80% of patients with ERM or VMT, which we haven't talked about yet, will improve by at least 2 lines following a vitrectomy. So it's actually a very successful surgery when done at the appropriate time and done correctly. So this is a 67-year-old male who was 20/70, and hopefully you can appreciate there that there are some tractional lines here. Okay, this is your epiretinal membrane, and it's all the way over here. And you can even see that some of these blood vessels are changing trajectory. So I would argue that this patient probably has a combination of a grade 1 and grade 2 ERM. And the patient's symptomatic. They're reporting shadowing, doubling of images that started a day prior, and the vision's 20/70. So keep in mind kind of all of these things that I'm mentioning to you as far as symptoms and vision go. What do we see? I already described to you previously, probably a combination of grade 1 and grade 2 findings. This is the patient's different images. We have a B scan here where you can see that the patient has had a complete PVD. Notice the clarity of the visuals, the vitreous space. Pretty significant epiretinal membrane here causing thickening. Interestingly enough, the photoreceptor integrity line looks decent. There may be a little bit of separation here, nothing crazy. But what really is cool is if you look at the en face image, which gives a different type of cut, it kind of cuts it horizontally versus vertically, you can really appreciate how the blood vessels and all the vasculature are being affected by this epiretinal membrane. So as far as the OCT goes, which is not true, do we see an ERM? Certainly. Is there foveal thickening from traction? Certainly. Is there a widening of the OPL? Certainly, and that's down here. And is there a full thickness macular hole? No. And we'll talk about that in just a minute. So the one that's not true is this has not developed a full thickness macular hole. So what do we do for this patient? Keep in mind the vision again, 20/60 or symptomatic. This patient has both. So 20/70 vision with shadowing with diplopia. So this is a patient that we certainly want to refer for possible intervention. I have a video here that we're going to try to play. If it doesn't, then we'll keep going. Okay, so you can see in that video that they went ahead and they did a peel, and then they'll go in and do a vitrectomy. So that's the procedure that they do with an epiretinal membrane. Okay, the next thing we're going to talk about is VMT. So just to emphasize before that, remember VMA does not affect any type of the anatomy. Remember that you can see the adhesion, almost again, an incomplete PVD with no distortion of the fovea. VMT differs importantly, because you will see that there has been an anatomical change at the fovea. So in this particular case, you can see that the ILM is being lifted up here by the posterior hyaloid. Okay, and we're looking at the 3 millimeter radius of the fovea. So we're looking pretty close to that center of the fovea. Remember that VMT is most common, just like ERM, in older adults and women. So lucky women. Why? Because we know that vitreous liquefaction is associated with declining post-menopausal estrogen levels. So that is why when you hit that, 55, 60, 65 and up ages, that is when all of these vitreomacular interface diseases really kick in. Other risk factors, high myopes, wet AMD, believe it or not, DME, vein occlusions, and diabetic retinopathy, anything that disrupts the natural anatomy of the eye. Same classification system as VMA. Focal, we're looking at, less than 1,500 microns. So you're going to measure point of attachment A to point of attachment B. And another example here, point A to point B over here. And then broad, again, being greater than 1,500 microns. Remember to look at point of attachment A to point of attachment B. And again, point A to point B. Why do I care? I'll tell you in just a minute. And concurrent, same thing. We're looking at, does the VMT happen in isolation in a healthy eye, or is there other disease, right? So this picture on the bottom has either a drusenoid PED or a CNV. So isolated focal VMT on top, concurrent broad VMT on the bottom. Clinical pearl, VMT will spontaneously resolve in about 11 to 53%. It's a very, very wide range. That is why oftentimes, most times, I will monitor these patients, because there's up to a 50% chance or a little higher that these are going to spontaneously release on their own, unless the patient has other risk factors that I'm worried about. So again, while this is a wide range, it illustrates how difficult it is to determine what's going to happen. And if it is going to happen, it happens usually between 15 and 18 months after onset of the disease. So when we talk about, what's going to happen to a patient with VMT, there's really 3 things that are going to happen. 11 to 53% of them are going to spontaneously resolve, right? So it's your choice whether or not you want to monitor them. There's going to be no change in the VMT over time, and patients will just have it. Or what we don't want to happen is situation 3, where you'll get increased tractional forces and ultimately a macular hole will form. That's the one we're trying to avoid. So what do we do for these patients? If they're asymptomatic and it's my clinic, I'm going to watch them. There is a big chance that these are going to spontaneously resolve or stay the way they are. If you're going to refer, if the patient's symptomatic or something is changing, the PIL is becoming affected, what's the retina specialist going to do? Usually, again, an ERM peel. I just showed you the video with a pars plana vitrectomy. Or they may do something called pneumatic vitreolysis, where they do a gas injection that promotes PVD formation. And the idea here is that if you get rid of the vitreous, which is the problem child, right? The vitreous is what's causing the VMT. If you can get rid of that, then hopefully we can get the VMT to release on its own. So I said before, why do I care if it's focal or broad? Why do I care if it's concurrent or isolated? Because they have different prognoses. If you look at both of these images have focal VMT. Notice, however, the image on the bottom has a broken photoreceptor integrity line. So even though these are both focal, that's not going to, that doesn't change who's going to do better. But the fact that the bottom image has caused some disturbance to the photoreceptor integrity line is certainly going to change the outcome of that patient's disease. Patient A, or the patient on top, is going to have I'm going to educate that patient a lot different than I'm going to educate the one on the bottom. So it's very important to understand what's happening so that you can best tell your patient what their overall, what they should expect overall. We don't want to tell this patient, you're going to be 20/20 after they do after they go in there and do a vitrectomy, because it's probably not going to happen. So we have to be confident by looking at these scans and looking at the eye, what we're going to tell the patient. Here's a 71-year-old female who says that the vision in her right eye has gotten progressively worse over the last 3 months and everything looks wavy. Nothing very obvious on the fundus image. And what I will say, which I'm sure you'll agree with, is that really OCT has been instrumental in vitreomacular interface disease because so much of this stuff hides. And a lot of this stuff, including incomplete PVDs, we find when we do an OCT. Pertinent finding, she's 20/80 in that right eye. Who would have thought, right? I mean, it's a beautiful view in, it doesn't look cataractous, but yet vision's very reduced. There might be some vitreous condensation if you look very closely on the photo. And here's a picture of the OCT. Certainly wouldn't have guessed that the vision's that bad, but this patient has a very significant epiretinal membrane with VMT, focal VMT. So that's why this patient's vision is pretty poor. So what are we looking at here? VMT due to anomalous PVD that disorganized the foveal structure, certainly. ERM causing traction on the retinal surface, certainly. Is it broad VMT? No. Remember to measure from point A to point B. Okay. And we worry when you have focal VMT that those are more prone to lead to a macular hole just because you're pulling with more force in a narrower area. So again, when we go back to why do we care if it's focal or broad, because we're looking at the propensity for that VMT to go on to develop a macular hole. And again, it's more likely to happen in a focal VMT. So case management, patient is symptomatic. It's a focal VMT. There is an ERM. This is a no-brainer. This patient should be referred. This is just kind of an example of how things can go awry but do well after intervention. So, a presentation, the patient had a broad vitreomacular adhesion. Also, we can call this a stage 2 incomplete PVD or stage 2 PVD. 1 year later, the patient went on to develop focal VMT, right? So you're not going to do anything for a patient that has broad VMA, patient that has incomplete PVD. But this was one of the patients that unfortunately went on to develop focal VMT. Nothing was done because I certainly wouldn't have done anything, right? I watch these patients because there's a big likelihood that they're going to go away. But this happened to be a patient that 3 months later went on to develop a full thickness macular hole, but had treatment and did very well. So just an example of, you can do everything right? Even if we had referred the patient at this point, no one is going to touch that patient. It's just, unless there's a symptomatic, something else that we don't see here, there's definitely a reason to refer. So just things certainly can happen. Okay, the next one will be full thickness macular hole. So a full thickness macular hole is defined as a break all the way from inner limiting membrane down to RPE. Okay, you have to dynamically move through the OCT scans to ensure that you're not missing it. Because if you only look at one scan, you may not see the complete break. So if you look at the OCT, again, complete loss from ILM all the way down to RPE. And when you look at the patient clinically, what you're going to appreciate is this maroon appearance because RPE is maroon in color. So when you have that perfect circular lesion and you see a maroon coloration, you are visualizing down to RPE. So again, the IVTS classified full thickness macular holes. And it's very important if you have OCT that you're familiar with this classification because we've always used the GAS criteria, and the GAS criteria is a little bit challenging to remember. I'm getting older, so I can't memorize things like I used to. Using OCT is easy, okay, because all you have to do is look at the size of the defect on OCT. And I'm going to show you in just a minute what I mean by that. If the defect measures less than or equal to 250 microns, it's going to be considered small. If it measures 250 to 400 microns, it's medium. And if it measures greater than 400 microns, it's large. Why do I care? Because there is a direct correlation between the size of the hole and the actual outcome of the patient. So taking a minute and using the line caliper or the ruler on your OCT is going to help you to educate the patient properly on what they should be expecting post-surgery. So here's an example of a small full thickness hole. If you were to measure the smallest aperture, which is where my white arrow is, that measures 112 microns. So this is a patient that probably is going to do extremely well after surgery, right? It's a very small hole. They do the ILM peel, they do a vitrectomy, they have a very good outcome. With a medium hole, remember to measure the smallest point of attachment or detachment, I should say. This one's 264 microns, so it's a medium. Still, very good success rate with vitrectomy surgery. But what begins to happen the bigger these holes get, right? This is a 400 micron, and I'm going to show you in a minute, they can be even bigger. The probability of having success is much slimmer when the holes are this big. Okay, so why I'm asking, why do I care? Because what we tell our patients is critical. Okay, we don't want to tell the patient one thing and then they go and have a different outcome. Recently, the CLOSE study looked at really big holes. So they looked at large, extra large, extra large, and giant, really to look at how do these patients do after surgery. And, it really, again, the larger they are, the less likelihood that they're going to do well. But this kind of built on the IVTS classification just to continue so that we can differentiate between someone that has a large and, let's say, a giant hole. Management of these, the new classification demonstrated again that these holes, large holes, extra large holes, can be treated successfully with ILM peel and ILM flap techniques, which I'm going to show you in just a minute a video of. But remember, again, this is obvious. The bigger the hole, the less likely that the complete outcome is going to be better. So this is a video here of this ILM flap technique, which hopefully it'll play here so you can see how cool it is. There's no sound here, but they're just showing you the size of the hole is 580 microns, so it's large. You can see how delicate this procedure is. Not a day when you want to have a ton of coffee. So here they're peeling the inner limiting membrane. And you're going to notice how they're going to take this tissue and they're going to actually stuff it into the hole, which is what this flap technique is. So here they go. They're, instead of removing the entire tissue, they're going to take it and push it into the hole. So again, this is being done now with the large and extra large holes and really they're having pretty good outcomes. So I think that is just so super cool. And look at that 1 week after surgery. So really incredible what these retinal surgeons do. And there's the OCT. The patient had a beautiful outcome, considering they had a large full thickness macular hole before they started. But remember, it was like 450 or 460 microns. So bigger it is, the harder it is to do, but really neat. So that's called the inverted ILM flap technique. Okay, so the first way we classified it was based on size, small, medium, large, extra large, whatever. The second way we classify it is we look at the relationship of the vitreous to the retina. If the patient has had a complete PVD, and, the vitreous isn't involved, we call it secondary. But what if there's still vitreous involvement? What if there's VMT? Then we're going to call it primary. So if you look at the first OCT on top, the way I would categorize that, number one is primary, because you can see there's VMT. And this is probably a medium, small to medium full thickness hole. So I would call this a primary, medium full thickness macular hole. On the bottom, secondary, medium full thickness macular hole. So again, we're looking at that relationship between the vitreous to the, to the ILM, to the macular hole. Here's another example of a 71-year-old Hispanic female. She was eccentrically fixating. She had scattered drusen. She was a pseudophakic, and you can see that maroon color indicating likely a full thickness macular hole. Looking at the OCT, notice number one, there is vitreomacular traction. Okay, so that makes it primary. The second thing we're doing is we're looking at the aperture here. What size is it? This is probably small. Is there not an ERM? I would argue there's probably a small ERM here. So the best answer here is probably going to be number two. It's a full thickness macular hole. It's small. There's VMT present and there's an ERM present. So what are we going to do for this patient? Refer. Okay. There's never anything to think about with a full thickness hole. We refer every single full thickness hole out. And the treatment options either are doing a vitrectomy ILM peel or the inverted ILM flap. The last one, anomalous, coming from this kind of section, is a partial thickness hole. When we talk about partial thickness holes, remember that there's going to be some retina left. That is how we distinguish a partial thickness hole from a full thickness hole. Once we get into the category of partial thickness holes, there's a couple of different flavors or a couple of different categories that are embedded within this partial thickness hole arena. So the first word that goes with partial thickness hole is called lamellar. First thing to notice before we go into the details is if you look at the scan, you can see that there is a break at the ILM, but if you move down, hopefully you can appreciate that there is lots of tissue here, okay? Because there's tissue here, this is not full thickness. So before you do anything, you want to establish, number one, is it full thickness or is it partial thickness, okay? If you've established that it's full thickness, I just went over the classification. You're going to look at size, you're going to look at the vitreous. If you've determined that there is tissue left, then you're in the partial thickness category. So the first type of partial thickness hole is lamellar. Lamellar comes in two types. The first one is called a tractional lamellar hole. Tractional means that there is an epiretinal membrane, okay? The epiretinal membrane is causing traction, which is resulting in what we call a foveal schisis. A schisis is a separation of the neurosensory retina. When you see these scitic-like cavities or these pillars, that is a foveal schisis. Tractional lamellar holes tend to take on mustache-like appearances. So if you look at this, you can see that it's kind of excavated both ways out. That is a mustache-like appearance. So again, when you're categorizing, number one, it's lamellar and it's tractional because there's an ERM, which is why it's called tractional, and foveal schisis, or a separation of that neurosensory retina tissue. And it's partial thickness because there's still tissue here. The second type of lamellar hole is called degenerative. Degenerative has a top hat appearance. Okay, so you can see that there's rounded edges. There's no ERM. What you're noticing here with my blue arrow is something called epiretinal proliferation. It's not an epiretinal membrane. I'm going to show you on the next slide. It doesn't have tractional characteristics to it. Okay, so you get this, top hat or rounded, instead of the scitic cavity, it's a rounded edged cavity. So here's a blown up picture of a lamellar degenerative hole. So first thing we establish, we can see that there's tissue. So we know it's not full thickness. The second thing we're looking for is there an ERM? This is not an ERM. This is called epiretinal proliferation. Notice this over here might have a little bit of an epiretinal membrane appearance, but this over here is epiretinal proliferation. You get this isoreflective or homogeneously reflective tissue right above the ILM. Okay, and that is consistent with a degenerative macular hole, meaning that if the posterior hyaloid tried to detach, it didn't attach, and it left stuff there, but that stuff did not impose a tractional force there. Okay, the other thing you're going to notice is the rounded edges, almost like a top hat, put it in that degenerative category. Big time problem here, though, is that the photoreceptor integrity line and RP are disrupted. So even though this patient doesn't have a full thickness hole, their vision is not going to be great because of what's happening at this outer retinal space. So remember, not only are we looking at what's the visual consequences going to be from the hole, but always look at that outer retina and the impact that the macular hole or partial thickness hole had on the outer retina. So kind of a quiz here, picture A, picture B. Before I show it, take a second to think about it. Hopefully you can appreciate that picture A is the degenerative one, picture B is tractional. Notice these white carets are pointing to the epiretinal proliferation. Notice the rounded edges, the top hat, that's degenerative. This one has the epiretinal membrane, excuse me, the foveal schisis, the schitic cavities with that mustache-like appearance. Okay, just different appearances. What do you do for these patients? Next slide. Hold on, I'll tell you. Most lamellar holes are going to remain stable. 13 to 21% will show decline over about 1.5 to 2 years. Many surgeons choose to perform surgery when the patient becomes symptomatic or when vision becomes reduced. Most people are not going to refer out or touch a partial thickness hole, okay? Especially when vision is good. Again, if you're seeing evidence of change over time, patients complaining about vision that we know is related not to a cataract or something else, but specifically to the retina, that's a different story. So when you're looking at management, if there's an ERM, yeah, you can do an ILM peel, you can do a vitrectomy, just like we talked about before. The degenerative ones, not a whole bunch you can do. You can go in there and there's something called a lamellar hole epiretinal proliferation surgery where they go in and they peel off that. But I'm going to be honest, most doctors are not touching these eyes. Okay, so every patient that has a partial thickness hole should be treated independently of the next, and the decisions that we make should be made based specifically on that patient and the complaints that that patient has. Okay, in my career, I don't know that I've ever referred out any partial thickness holes unless there's some type of vitreomacular traction and the patient is symptomatic. Or again, if the patient is losing vision over time and I don't have any other reason to qualify or to make sense of it. Let's see what one more. Is this another video here? Let's see what this one is here.
This is a case of a lamellar macular hole with preoperative visual acuity of 20/80. The OCT demonstrates the typical degenerative lamellar hole appearance with lamellar hyperepithelial proliferation as well as a top hat appearance. Here in this first part of the vitrectomy, indocyanine green with D5W is placed on the macular surface, and then a finesse loop is used to elevate the tissue to create an ILM flap from which both the ILM and the ERM tissue is going to be removed. Once the tissue is elevated, a Tano asymmetrical forceps is used to elevate both the ILM and ERM tissue together, and it's brought up to the whole edge. Care is taken to really go to the edges of the flap of the tissue to elevate and get a large purchase area rather than pulling from the center and avulsing the tissue from the macular hole. Again, going and working from the periphery toward the center of the hole allows and makes sure you have a large purchase area which can then be used to stuff the hole at the end of the procedure. Once the tissue is firmly brought to the hole from each side, from the tissue will then be trimmed with the microvitrectomy on shave mode and an effort not to remove the entirety of this tissue. Finally, an air fluid exchange is performed to then allow for complete gas exchange and placement of the patient face down at the end of the procedure. Care is again taken not to revulse the tissue at the time of the air fluid exchange. Post-operatively, the patient has acuity of 20/40, 3 months after the surgical procedure.
So really cool stuff. These patients can do really well. Okay, so let's just go to the very last thing I wanted to talk about in the last minute that we have is the other kind of partial thickness hole. We have lamellar, we have a macular pseudo hole. So if it doesn't fit into that category of top hat or mustache, and it looks just like a U, that's called a pseudo hole. It's also partial thickness. Notice that there's tissue here, but there definitely is a defect in that contour at the fovea. So when you see this sinkhole appearance, it's just a round, like just a U like that. That one we call a macular pseudohole. Can also happen from an epiretinal membrane, but it doesn't result in a foveal schisis, and it doesn't result in a mustache appearance. So just a cleaner look. And really, we're not gonna do anything for this. It's the same kind of thing that we talked about before, unless the patient's symptomatic or vision is changing over time. Here's another example. Here's your epiretinal membrane. Here's your macular pseudohole. And appreciate that in this particular OCT, there is that thickening again from the epiretinal membrane. But again, no one's gonna touch this eye unless it doesn't fare well for the patient.